All right, let's dive right in and solve a classic clinical puzzle. And we're going to do it right at the bedside with nothing more than an ultrasound probe. It's a common question, and trust me, getting it right is absolutely critical.
So, picture this. You're scanning a patient who's having trouble breathing. You put the probe on their chest and you see this, a lung consolidation. But what exactly is it? Is it an infection like pneumonia, or is it a collapse, what we call atelectasis? Getting this right and getting it right fast can change everything for your patient. And look, this isn't some textbook trivia, right? This is a real-time challenge you're going to face over and over again. Your patient is struggling, and your next move, the right treatment, depends entirely on figuring out the story this screen is trying to tell you. But the cool thing is, the answer is right there in your hands. Your ultrasound probe holds the key. The answer isn't in some static image, but in a dynamic sign that you can actually watch moment by moment while the patient is breathing. So what's this magic clue? It's something called an Air-bronchogram. Seriously, this one sign is the key that unlocks the entire mystery. Okay, so what is an Air-bronchogram? Well, normally you can't really see into the lung with ultrasound because it's just full of air. But when those tiny air sacs, the alveoli, get filled up with fluid or just collapse, something amazing happens. The bigger airways, the bronchi, can still have air in them, and that's what we see, these bright white lines or little dots popping out against that dark, consolidated lung tissue. Here's a super simple way to think about it. Imagine the consolidated lung is like a big block of jello. The air bronchograms, they're like little air-filled straws that are suddenly visible, just suspended right there inside. It's a dead giveaway that something's up deep inside that lung. Okay, but here's where the real detective work begins, because not all air bronchograms are created equal. The critical difference, the thing that's going to tell us if it's pneumonia or atelectasis, is whether they're dynamic or static. Let's talk about the dynamic ones first. When you see a dynamic air bronchogram, you'll actually notice those bright white lines moving. They shift and dance with every breath the patient takes. It's often this kind of subtle fanning out motion. So, why the movement? It's actually super logical. It means the airway is open. It's patent. Air is physically flowing in and out of those bronchs with each breath, and that's what makes those little air pockets we see on the screen shimmer and move around. Now, for the flip side, the static air bronchogram. And as the name suggests, these guys are totally still. They don't move at all. The patient breathes in, they breathe out, and those little white lines just stay put, completely frozen in place. And you can probably guess why they're static, right? It's the exact opposite reason. The airway is blocked. Something, maybe a mucus plug, a tumor, whatever, is stopping the air from moving. So the air that's already in there is just trapped. No flow in, no flow out, just motionless. So you see, it really all boils down to this one simple, powerful difference. Dynamic means air is flowing through an open, patent airway. Static means air is trapped because of a blocked, obstructed airway. Flow versus no flow. That's the game. All right, so we've got our evidence. We know what to look for, and we know what it means mechanically. Now it's time for the big reveal. Let's connect these clues to our two main suspects, pneumonia and atelectasis. And here it is, the moment of truth. If you see those dynamic, moving air bronchograms, that is a huge pointer towards pneumonia. It's telling you the lung is filled with infectious fluid, but the airways themselves are still open for business. And what if they're static? What if those lines are just sitting there, not moving at all? That points you straight towards atelectasis. The lung has collapsed and the airways are blocked, trapping the air inside. Let's just lay this all out nice and clear. Movement present, airway patent, ventilation happening. You're thinking pneumonia. Movement absent, airway obstructed, no ventilation. You're looking at atelectasis. Now, check out the specificity. This sign is highly specific for pneumonia, so you can be pretty darn confident. It's a little less so for atelectasis, which is just a good reminder that, clinical context is always king. And that actually brings us to a really important final point. This sign is incredibly powerful, no doubt, but great diagnostics is never about just one thing, right? It's about putting all the pieces of the puzzle together to build the complete picture. So you're not just hunting for air bronchograms in isolation, you're putting it together with all the other classic ultrasound findings. Do you see B lines? What about a pleural effusion? Any signs of volume loss, like the diaphragm creeping up? Every single one of these adds another layer of confidence to your diagnosis. So really, you can think of it like a simple formula. Dynamic signs plus that liver-like appearance of the lung, what we call hepatization, that equals pneumonia.
On the other hand, static signs plus other clues of volume loss, that's your atelectasis. And this, right here, is why this matters so much. It's not just about being clever with an ultrasound. As the source material puts it, recognizing these patterns enhances bedside diagnostic accuracy and directly informs patient management. You're making a real difference, right there, right then. So there you have it. You now hold the key to cracking this common bedside mystery. It's all about movement versus stillness, an open airway versus a blocked one. So the next time you lay that probe on a patient's chest, what are you going to find?